Hey, we're back. I'm Jay, and this is
Jay.
Jay. It's Jay and Jay.
Yeah.
Yeah. By the way, he likes to snuggle dogs. He's got his dog snuggling T-shirt, but there's no dogs here.
There could be a dog
Yeah,
here.
we could bring one.
Yeah, right?
Yeah.
It's
Anyways, today we're gonna look at this all-inclusive thing called shock. There's a lot of different types of shock,
there are. And today we're actually going to be focusing on distributive shock.
and distributive shock has.
Way too many different types of shock associated with distributive shock. So distributive shock is this big umbrella term that we use to talk about several different types of subcategories of shock. So just to make it sound confusing, however, I promise you at the end of this, you'll have a really good understanding of what distributive shock actually is.
All right, so let's jump into it.
Let's jump into it. All right, guys. So big heading here, distributive shock. I say that the road's clear, but you're not going anywhere. Okay, and this is going to make sense as we go through this. Okay, so when we look at shock, we want to kind of think of what are we doing? What is shock first off? So when we say something is shock or someone is showing signs of shock, what do we mean?
What do we mean?
Yeah,
Well, we're looking at where the body's starting to compensate, right, for one another.
exactly.
The
Now,
different systems in the body, right?
exactly. Now, why is this important?
Why is this
Why do
important?
we care about shock?
Because we need to have perfusion.
We do. And perfusion, Jay, what in simple terms, what is perfusion?
Perfusion is getting our nutrients and oxygen to all our cells that are needed.
Exactly. So
Right.
if I am not giving
Creates homeostasis.
yeah, exactly. Perfusion is essential for homeostasis.
Yeah.
So if I am not getting oxygen to my cells or nutrients to my cells or removing wastes from my cells, that's bad.
Yeah.
Okay. And so that is primarily what shock is. Shock is simply just really junk perfusion. So if my perfusion is junk, then my cells are going to be starved of nutrients and oxygen and build up things like carbon dioxide, acidosis comes in there, just things are bad. Now, we can look at this in a different way as well. So one of the reasons why shock is so bad isn't just that I'm starving my cells,
Yeah.
but that's how we die as humans.
Well, that's the end results, right?
Yeah, right. And so it doesn't matter if I have old age. Okay, so I could have decrease in my nervous system's ability to function. So this could be neurogenic shock. I could have a heart attack, which can be cardiogenic shock. If I'm stabbed and I'm bleeding out, this could be hemorrhagic shock. If I
Yeah.
have diarrhea and I'm puking because of my amazing trip to Mexico, this could be hypovolemic shock. So it doesn't matter, but the end result is if we don't look after shock in the pre-hospital setting or even as an in-hospital provider, what's going to happen?
You die.
That's it. It's over. Okay, so shock is incredibly important. Let's jump.
It's very important to recognize it early.
Incredibly
That's why
important.
you need to understand how shock works, so we can get in there before the eight ball, right? We don't want to be behind the eight ball. You want to be in front of the eight ball.
Exactly. So I'm actually going to give you some pretty scary stats with that, but 100% we want to recognize shock
Yeah.
early. All right. So when we are looking at this guy here, this is pretty much what we've just talked about. So shock, life-threatening. It's how we die. Like, I mean, if we're going peacefully, it could be from shock. If we're going in this acute, really horrible way, like someone stabbed me, it could be shock. We know that we're not getting oxygen to our cells. We know that we're not getting nutrients. We know that we're not taking away those waste products. And a cool thing to understand is if we do recognize this quickly, as we're talking about, we can mitigate this, man.
Yeah.
Right? That's why we're here. That's what you pre-hospital
Well, that's
providers.
what they call us,
Yeah,
right?
right, exactly. So you guys, you show up, you roll on scene, you recognize this, and you start treating it right away, and that is good for your patients. It actually is good for your patients down the road as well, as we're going to talk about. So,
And that comes back to recognizing the shock and starting treatment early, because as soon as we see shock, it's easier to treat it earlier than later,
100%.
right?
But sometimes shock likes to mimic itself. We'll go into that as well. Now, we've talked about this as well. We have poor perfusion, nothing too crazy there. So hypoxia. Now, when shock is kind of getting away from us, we can say that it becomes life-threatening with a few specific, however, not necessarily rules, but a few specific kind of signs that we see. So if we have severe hypotension, that is, if my systolic is less than 90, that sucks. if my mean arterial is less than 65, we're starting to panic as providers. You know, we start seeing these
Yep.
things and we're like, okay, what tools do I have in my toolkit to reverse this? Okay. Now, shock in the simple form, 4 categories. That's not a big deal. I can count to
Nope.
4.
Yep.
It's one hand. But like I said, we're going to subdivide this. But when we look at these 4 main categories, we've got distributive, which we're talking about today, hypovolemic, cardiogenic, and obstructive. So we'll look at those other 3,
Yep.
you know, at a different time. But today we're going to focus on distributive. Now, there's also this kind of hidden, nuanced 5th type of a shock that we don't typically talk about, but it's undifferentiated, which means that I know my patient's in shock. I just haven't figured out why yet. So it could be hypovolemic. I just don't know why. I know my patient's in shock. I just haven't.
Because they have all the signs and symptoms, right?
Exactly.
So actually, just even recognize that even as a beginner level, like EMR level,
Yep.
right, emergency medical responder, even if you just understand that your patient is in shock, you may not have nailed it down whether it's cardiogenic, hypovolemic, but you understand that there's something going on and you need to intervene.
Exactly. So like I said, today we're going to be focusing on this distributive. Let's jump on in. Why do we care, Jay?
Because it's actually it's the biggest killer of all
Yeah.
for all of us, really. And like you said, it's the end result is death from shock, right? If we don't stop it, if we don't put a wedge in place, and just even if we're like I said, EMR, PCP, even as an advanced care paramedic, the idea is like to stop that from getting worse.
Exactly, right? So we definitely need to mitigate this as quickly as possible. So we're looking at a study from 2022 here in JAMA, okay? And what this was looking at was when we look at shock, we're looking at a population-wide incidence of 76 per 100,000 people. And it's more common in men, which makes sense. Especially, you know, we like to do things
more silly things.
100%. We don't look after our bodies as well, right? Older individuals, rural settings, just simply because it's tough to get that EMS out there, right? And the lower socioeconomic status is also a reason why shock incidents can be higher.
Yeah.
Now, also, in a pre-hospital setting, this is actually kind of common. So when I say this, you're going to be like, oh, this doesn't sound like much, you know, 6.8 per 1,000 cases. But think of that. How many cases do you go on a year? You know, if you go like 5, 6 a day sometimes, like it doesn't take long to get to 1,000. So this is...
Well, the 1 year I did 900.
1 year?
Yeah, 1 year I did 900. 12 months I did 900.
See, that's crazy.
Right? So if you think, that was close to that 1,000.
Right, in 1 year.
Yeah.
And when we look at these aren't a typical like load and go. Let's you know, do a slow transport. This is a oh my god, I need you in my ambulance yesterday. So this is insane. Now it gets even better here. In the pre-hospital setting, in the incidents, Jay, where you had almost you know when you saw this right away.
Yep.
We are looking at if you have a patient, so 6.8 per 100,000. That patient that was 6.8 there. Sorry, in 1,000, not 100,000. Sorry, I misspoke there. But we are looking at a 30-day mortality rate of 33%. That is 1/3 of your shock patients that you see pre-hospital are not going to make it 30 days.
Well, and you think about it. So when we get into it, like there's the different stages of shock. So if this person's farther along, that number probably goes up a bit.
100%.
And if you catch them right out of the gate, right, where they're still compensating, the number probably gets lower. But that's why it's important because it's 1/3 of those patients are going to have a die within a month.
100%. And that's crazy, right? Now, we can break this up even further. So when we start looking at some of these subcategories of patients. Now, for females, I love it here because we're talking about specifically with cardiogenic shock. It goes up with females. And that's because a lot of the time, Jay, as you're going to know, is like your female patient doesn't have your typical Hollywood signs of cardiac issues. You know, they don't have that crushing chest pain and it radiates. They have the, I'm tired and cranky.
Yeah.
So
I'm nauseated, right?
Exactly. So obviously when we look at things like that for the female patients, these incidents can go up simply because when you arrive on scene, Jay, you have a female patient who's lethargic and has been, you know, she has some lower back pain and maybe some indigestion.
Yeah.
Are you like, oh, yeah, 100% you're having a heart attack?
Well, most of the time, like you said, when we were first taught, it's always crushing chest pain down the left
Oh,
arm, jar pain. The problem with these female patients is, like you said, they come up. So it's the one that you said they just have nausea, and then they tell you for some reason when they go up and down the stairs, the nausea gets worse.
right, exactly.
Right, so that's that exertion on the heart.
Yeah, so originally we think nausea, we're going to give some Zofran, kind of deal
Yeah,
with this and go away, but then we piece this out. We start going deeper into this situation, and as you
yeah,
said, oh, exertion equals, this nausea happening. So with things like comorbidities, when you're intubating in the field, these are all things that increase
yep.
the rate of people dying from shock, which sucks.
Yeah, and it makes it way harder,
Yeah,
right? Like, because you're actually dealing with complex. And the older they get too, they have more complex medical issues.
100%.
So when you add all those in, you're not just dealing with the shock or whatever's going on at that moment. You actually have to understand that this person has, let's say they're on a beta blocker because they have hypertension,
Yeah,
but you can't figure out why they're not tachycardic because they should be in shock, but it's because they're in the got the beta blocker. So it doesn't matter. Like you're having a harder time getting that heart to go faster to help compensate.
exactly. So the more these comorbidities, the more things are going on with the patient, equals the worst outcome
Yeah.
for that patient in the long run. So 30-day mortality, 1/3%. All right. So let's look at this distributive shock here. Okay. So, oh, look at that.
Yeah.
There's a bunch of extra Z's in
Yeah.
there. I don't know why. You know what, guys? It's a beautiful spelling mistake. But we're looking
I
at.
don't think it's a beautiful spelling mistake. I think you're just trying to get across the point of vasodilatation.
Yes,
Right.
exactly. I am. So everyone, that's the word of the day is vasodilation with three Z's. So distributive shock, that is one of the things we're looking at, is we can't distribute things. Like I
Yeah.
said, the road is clear, but you're not going anywhere. So when we have mass vasodilation, well, that puts strain on my heart.
Why does it do that?
Well, because I have this like, so when we look at my vessels and they get all giant for whatever reason, which
Yeah.
we're going to talk into, then my heart has to make up for
Mm.
that decrease in blood pressure. So I want to go tacky. And
Because your container is bigger, right? Your basal
exactly as my container
vascular
goes,
system gets way bigger.
exactly. So as the container gets bigger, the pump has to start pushing.
Yeah.
Okay. So distributive shock, we're going to go through a few different types here, guys. So we're going to look at sepsis. We've all kind of learned about septic shock, so we'll spend a slide there. Systemic inflammatory response. Oh, there's another spelling.
Jesus, like,
Jeez. Who wrote this? I
um,
should say anaphylactic.
oh,
But you know
I
what?
thought maybe you had something new there.
I wish. No, no, no. I'm gonna have to fire my editor. We're going to look at neurogenic as well, which I love, and
Yeah.
endocrine shock, which is one that most people probably haven't heard of because in the pre-hospital setting, we don't really care about it.
No.
Okay, so let's start off here. Sepsis. So what is sepsis? We've all heard of it.
Well, it's when I get sick, right?
Exactly. So what's happening though, Jay? Like if
But
I'm sick.
I got a cold, right? And I get sepsis.
Yep. Yep. Well, I mean, not from a cold.
Okay, just
I
checking.
mean, but
Right.
like, I mean, you like it.
It's just usually comes to like a pneumonia. It's more of a widespread, kind of larger infection, right? It's not like you got a cold and you're going to get sepsis.
I mean, you can. It's been documented.
Well, if you have core mobilities, all those other things, right? You add all other things, you can get that. Your cold turns into pneumonia and it just gets worse.
Exactly. So like if we were looking at someone, let's say, who has AIDS.
Yeah.
Right. So HIV, that's progressive full-blown AIDS. They have an immunodeficiency. So that cold could then lead
Yeah.
to something like sepsis, but not that common. Okay. So when we look at sepsis, we are looking at, once again, the main distributive effect of we simply cannot pump the good stuff, the oxygen, the nutrients to the organs. Okay. I have a few things here that you guys don't really need to know. At the very bottom there, I said it's really commonly associated with gram-positive bacterium, strep pneumoniae, enterococcus, things like that. You can look into it. It is super interesting, especially how we start staining things to see, what is actually happening within the cell walls of these bacterium. But as EMS providers, we never do that.
Yeah, we wouldn't be doing that.
No, exactly, right?
So you're probably better off to get them to a hospital than start doing that.
Exactly.
In their house.
Yeah, start doing a gram stain. Yeah, we're probably wasting a little bit of time doing that. But yeah, so the big thing that we're looking at here, once again, is that really crappy perfusion, right? And that, poor that hypotension.
And how does the perfusion get crappy though?
How does the perfusion itself get
Yeah,
affected?
like what is causing that in septic shock, like the root shock? What are we doing there, right? It's the container again. It's too
Oh, yeah,
big,
yeah,
right?
100%. So you betcha. So we get these different
Mm.
abnormalities due to the bacterium that are kicking around there. So one of the things, so we get things like chemotaxis, which is trying to get these white blood cells to the area, which is a good thing. However, as we start doing this, the thing we need to remember is the body's trying to fight something off. Okay. So we're launching these different immune responses, which is a good thing, but we're also going to do a few things like increase um, our fever.
Yeah,
So as our temperature goes up, which is something you're going to look for on these patients, we need to remember that our body is doing that because it thinks it's trying to help us out. So when back in chemistry, you're at high school or in university, what is one of the simplest ways to increase the rate of any reaction? Is you add heat to the system,
yeah,
right? And that's all your body's trying to do here. Okay, so when we add heat to the system, our body's trying to increase those chemical reactions to fight off these bad guys.
yeah,
However, what happens with that is the downstream effect of we increase the container.
yeah,
Now, not only have I dropped my blood pressure, have I dropped the ability to get those, those leukocytes and those good, like phagocytotic cells to help fight this bacteria, but I've also increased my temperature as well. So when we look at these patients here, low BP, increased fever, they're gonna look and feel like junk.
Oh yeah, and the biggest thing too is like it's that container's just gotten too big,
Too big. Yeah.
right?
Heart rate's gonna
You
be up.
get
They're gonna be
some
sweaty.
intercellular like fluid going into the tissues, like at the low level, so your vascular bed even gets bigger, doesn't it?
Yep. 100%.
Right. So now you
100%.
have way more space to fill, but you don't have enough
Exactly.
fluid volume. You don't have enough blood. You don't have that, so that space is just way too big. And that is, as an EMS provider, there's very few things you can do to really treat that. Other than the biggest one is that recognition, especially in
Yeah.
sepsis, because they need antibiotics right away.
Yeah. There's nothing in field that we can do with this.
So I mean, there's things we look at, right? We can give them a fluid, but because the space is really big, if we give them a whole bunch of fluid, that's not going to benefit them either. It's going to get that pressure up. It'll help a bit of perfusion, but we could overload them now with the fluid.
Exactly.
As an ACP, I'd probably look at a vasopressor, right? So we're going to kind of
Definitely.
squeeze that tank a bit, and all we're really trying to do is just get to a good level of perfusion, right? So we're oxygenating, we're getting that blood and fluid to the brain and to the heart.
Exactly. But this individual needs
Yeah,
advanced medical care.
we're not fixing this in the field.
No, exactly. They're going to be put on a wide spectrum antibiotic. But our job in the field is, as Jay just said, it is to make sure we just get their pressure to kind of normalize somehow
Yeah,
without overwhelming the system with fluids.
yeah, and the biggest thing is just get them to the hospital.
Yep, you betcha. You betcha. Now, systemic inflammatory response syndrome. This is not something that we typically talk about within EMS. Okay. So it's a fun one though. Okay. So let's say here we have a upper respiratory tract infection. So we have a bacterium that's going in there. So this is kind of starting to like fester, kind of make its way. It can go down to the lower respiratory system. So this is showing COVID-19 here. We all love talking about COVID. We haven't had enough of that. Now, what's happening is I get inflammation in various systems. So with COVID, so I get COVID and I know I have a respiratory issue.
Yep.
Because we're all coughing it. Heck, in EMS, we had to stop using nebulized medications because we had that droplet
Yep.
precaution, all that kind of fun stuff. But what else was happening with that? So it wasn't just locally to the lungs, we had other body tissues being affected. Okay. So once again, if I have COVID starting in my lungs, yeah, I get this vasodilation. Well, now I've left my lungs and now I'm working on a systemic pathway. I've left the initial site of infection. Now, we also saw patients with COVID that we would have things like kidneys shut down in super severe cases. So now I've gone through the blood system, I've made a home somewhere else, I've gone to the kidneys, I've created damage there. There were instances of cardiac issues, whether or not they were related directly to COVID or if they were secondary. Um, it's something I never really looked into, nor do I
Yeah.
really care. I just know that I have outside my area of infection, I've created inflammation in a multitude of different areas. And so we're looking at systemic inflammatory response.
And that's kind of like when we talk about, right? Like you say, like just the pneumonia.
Yep.
you get super sick. When we talk about sepsis becomes a widespread.
Yeah,
So I can have pneumonia, which means I have an infection, but doesn't necessarily mean I have sepsis.
exactly.
Sepsis happens when it becomes widespread. It goes through my blood. The idea too that we get this vasodilation response, which actually would affect our kidneys, right? Because
Yep.
we can't put as much fluid through the kidneys.
Yep.
We can't filter stuff through the liver as well. So all those and that infection, like you said, just not just COVID, gets into the bloodstream and it starts manifesting in other places. So it becomes a whole systematic response.
Exactly, right? So even though we get that initial infection in our lungs, well, heck, this is actually going to be much bigger than
Yeah.
that. Okay. And there's other bacterium that don't do that, right? Like, I mean, quite a few bacterium, they'll find a nice little house, whether that's in the lungs or the kidneys and your gallbladder or whatever. And that's where they'll do their thing.
Yeah.
Like when we look at Neisseria meningitis goes in those meninges. However, we're not really going to find a virulent form of it, let's say, what would be a place where we're in my kidneys.
Yep.
Right. It's not
like a UTI, right?
Exactly. Right. So some bugs like to go to one area, some bugs like to fester throughout. Now, anaphylaxis.
So you spelled right there.
Right?
Good job.
You know, once again, I'm going to talk to my editor.
Yeah.
So I love anaphylaxis. I don't want anaphylaxis. I mean, I think it'd be a really shitty thing to go through, but I think it's just amazing of what the body's trying to do here. Okay. This is hypersensitivity, and it's an IgE response. It's an immunoglobulin E. Now, we can test this on blood work. We can test people's IgE levels all the time, and we do it for a lot of different things. Okay, so if you have allergies to cats, to dogs, to different foods, we're looking at what your IgE levels are. And IgE basically is allergy immunoglobulins. There's other things that come into play, but this is the easy way to look at it. Okay. So let's say we're at a park. We're having a great time, you and I, enjoying a sandwich together.
Yep.
Sharing a sandwich.
And you're allergic to peanuts.
And I thought it was wow butter.
Yeah, and I made peanut butter sandwiches.
Right?
Yeah.
Now I'm like, yeah, my tongue's and thick.
And at this point, I've been thinking you're having a stroke, but you don't have that.
Yeah, exactly, right? So I'm getting this response. My tongue's starting to feel kind of thick in my mouth. Now it's getting kind of me.
You're getting hives too?
Yeah, I'm getting some urticaria throughout those hives. Okay, now also, when you're noticing this on me, struggling to breathe and to talk, if you were to put a blood pressure cuff on me, what's happened?
Well, I think your pressure is going down.
Yeah, right? Distributive. So when we have an anaphylactic reaction, my pressure just tanks. My airway is constricted. So not only has my pressure tanked, well, my ability to oxygenate my cells at all,
well, it makes it harder.
Has gone down.
Because our tank got so much bigger, we cannot. What carries the blood, right? It's hemoglobin.
Yeah.
But if I can't squeeze that up to the brain or into any other tissues, I can't go anywhere.
So I can't pump the blood, and I can't get oxygen to bind onto the hemoglobin because I have this massive constriction with my bronchial passageway. Yeah. Oh,
man. But the thing to remember, though, is that this is not an allergic reaction, right? The key thing for allergic reaction is that it's just like I ate that peanut butter sandwich and I got some hives.
Yes.
Right?
Yes.
I got a little bit of swelling maybe in my lips, but it's basically one system.
Yes. Anaphylaxis needs more.
Yeah, we need 2 or more systems, and that's why it becomes bad. Because we got, again, like we're talking about sepsis, becomes widespread. Same with the anaphylaxis. It's hitting at more than one system. And the one system I'd like to point out is the one that, no one counts is nausea, vomiting.
Yeah.
Right? People start not getting this nausea, vomiting. People don't think, well, it can't be anaphylaxis because you're not closing your airway off. But if I have hives, right, and I got some nausea and vomiting,
that's more than one system. Yep. That's anaphylaxis. Now, one of the crazy things with this is we'll see, once again, no matter what, we get the vasodilation, so my BP is going to go down, which means what must my heart do to compensate?
Well, your heart rate's got to go up. So you become tachycardic.
Exactly. It has to. Now, if I'm having an anaphylactic reaction with airway constriction, well, what's my respiratory rate going to do? It has to go up.
It's going to go up.
Because if I can't do this, I got to do that. Okay. Skin becomes flushed. Flush turns to cyanotic.
And it gets flushed because we're vasodilated.
Exactly. And it becomes cyanotic simply because I can't get oxygen to my
Yeah.
tissues. Cap refill goes down because once again, that distributive shock, that vasodilation, so my cap refill is gonna, take longer.
So what's the biggest thing we gotta do? How do we treat it? The number one thing.
My favorite drug, good old epi.
Yep, epi.
Right.
We got to get it on board as soon as possible. What I found in the industry that we have guys that you get hung up on Benadryl.
Oh
yeah. You still got the two
And
systems,
Dex.
but they start with Benadryl first because they think that's going to be the first line drug. But really, the first line drug is epi. Epi makes the biggest impact
You
because
bet.
it stops those mast cells from producing to create this huge vasodilation. Right,
Yeah.
shuts down, helps you bronchodilate. Right, the bronchioles. It opens up, decreases some mucus production. So it really does make a huge difference. And in my experience, like I was talking the other day, we went for this lady that happened to have a nut allergy, and she ate some nuts while ate like a nice muffin with nuts on top.
Good old nice buffalo.
She even saw the nuts, which I don't get it. But we got their tongues hanging out of her mouth. She can barely breathe.
Yeah.
But 2 rounds of epi, she's now talking to us on fine.
Right. And that's something that like a more experienced practitioner will just do right away. And it's simply because like if you're doing, let's say, your initial set of vitals and you're like, oh man, this heart rate's at $120.
Yeah.
I don't want to give epi. That's just gonna make it. No, you do.
Yeah.
Yes, that rate's going to increase, but this is kind of like a good increase. Now, a cool thing that I'm going to kind of, talk about is there's a bunch of neat little mast cell, what's what I'm looking for here? I don't want to say issues or mast cell. Oh, gee, what's what I'm looking for?
But the mast cells actually, right, it's already seen that
Yeah.
allergen come in before. They builds off these mast cells. The mast cells are there to actually help us.
Yes, they are. But there's kind of a couple different mast cell syndromes
Yeah.
where if you give someone epi, it'll actually work the opposite way. Not common, and I know of one person that has them, and I forget what the term for the,
Yeah, I'm
for
not
the
sure
syndrome is, but it's super freaking cool. However, I'll make sure I find out what it is, and I'll let you guys know just to look it up because it's super interesting. But yeah, so anaphylaxis, we want to get epi on board. I mean, if that heart rate is jacked up, that's a-okay.
Yeah.
Because this is going to help them out in the long run.
Well, you actually might give the epi, and you actually might see their heart rate come down.
Yeah,
Which is you're not expecting that, but the reason the heart rate comes down
because we're fixing
we're
other
fixing the
system.
problem.
Yeah, exactly. So even though epi should increase heart rate, but because the heart rate's already jacked up so
Yeah.
high, but we're fixing the problem. It just
And we're not giving a lot. It's not like a cardiac arrest where you give the preload 1 milligram, right?
no, we're putting 0.3.
Yeah. Just to be very clear what we're giving.
Exactly.
Now, if you're an EMR or somebody else and they actually have a lot of times these people have EpiPens.
Yeah, totally.
So don't be afraid to encourage these people to start with their EpiPen before we get there, because in EMS, if the EpiPen's already been given, it gives us more time to work with this patient.
100%.
So as we talked about shock before, we have that spectrum of how sick they can get. If they get ahead of that 8-ball for us, we're laughing.
Yeah. Exactly. And if we're doing like your end title on them, we're going to say pretty shitty waveform there. However, once we get drug on board, we'll see everything kind of like level out. Oxygen saturation begins to go up and life is good.
Awesome.
So, moving on here. Oh, neurogenic shock. Love this. Okay. Let's say I'm working on my roof.
Okay. Well, how's your roof?
I'm going. Oh, jeez.
Did you have a harness on?
No.
Because I can see where this is going.
Harness?
Yeah.
What is it? The rodeo?
Yeah.
No harness. I'm
Yeah.
just raw dogging it
Yeah.
up there. And so I'm up on my roof, okay, and I slip because I'm not a mountain goat. I'm actually
Okay.
really horrible with my balance. Okay, and I
Steep slope house.
yeah, the roof is,
Yeah.
is pitched quite steep there. So let's say I slide down and I end up falling 20 feet. Now, what's the first thing?
Did you tuck and roll?
No, I don't tuck and roll.
No, it's just it's straight flat.
Yeah, I'm just
Okay.
smack. Right? You hear a big, and you also hear because
Yep.
knocks in the wind out of me. Now, obviously, we're going to think a few things. One is okay, definitely some spinal precautions.
Yeah, we got to worry about that.
100%.
You got to worry about your head. What hit first, the chicken or the egg, right? Did your back hit first or did your head hit first? But anyway, it's going to be a mess, right?
Exactly.
Mechanism of injury.
Yeah, this is
Right.
definitely a significant.
Sometimes you have to ask that question. You fell from up there,
Right.
and they go, "Yeah, I did." And you're like, "All the way up there?" Because you're still talking to me.
Yeah, exactly.
right? That does happen.
So this
So,
is going to be a significant mechanism
yeah.
of injury. And you're going to think initially, okay, bones are broken. However, if you do my vitals, and let's say you start to see things that you don't suspect, like, why is this dude's blood pressure kind of low?
Well, or even when we get into it, like if once we get into other shocks and you see them, you start looking at this guy thinking, this guy does not look shocked. He just fell 20 feet off the roof,
Yeah,
right? His blood pressure's really low. He's not tachycardic,
right.
right?
That's the thing. Like,
His respiratory rate really hasn't gone up, right? And he's, and they could be still mentating a little bit
right.
to a certain point, but they're not matching and they look quite flush and warm.
So here's the thing. My heart rate's normal.
Yeah.
But my blood pressure's down. That's not shock. Wait,
Well, it is.
but it has to be.
But this is this
But
is
my
the
heart's not.
trickier one.
But my heart's not picking up for it.
But the reason is the signaling is cut off.
Right. Here's the cool thing. So if we're looking at injuries above T6, okay, what's happening is I've created some type of disturbance in the force. Okay. Also, it's May 5th, and yesterday was May 4th, so Star Wars.
Yeah, I can see where you're going.
Thank you very much.
Yeah.
I appreciate it. So if my brain cannot send that signal to like my adrenals, like catecholamine release, guys, I need you to vasoconstrict. I need you to increase heart rate. I need you to do all these things because I got this vasodilation. If my brain doesn't have that connection there,
Well, the signal's going out.
it's just not.
It's just not going anywhere.
It's just not making it to where it has to go.
Yeah.
Right. Because if I'm above T6, think anything below T6, I can't get the signal to happen.
No.
Right, so everything below there, which is kind of all the stuff where I'm going to be releasing these neurotransmitters and these hormones to kind of help me out.
Well, we talk about, right? You got the receptor, you got the transmitter gets in there to the receptor, but this isn't being sent.
Exactly.
It keeps looking, but it's just not being sent.
Yeah, we don't have that ligand binding there.
Right.
So when that happens, we think that we know this is shock.
Yeah.
But it presents differently. Typically, what we want to see is that, we don't want to see this, but what we should see is that low BP and that jacked up heart rate. We need to make sure that these things kind of our body wants to counteract the low pressure with the increased heart rate. But with neurogenic, we don't get that.
No, it's because the signaling, the sensing can't go back and forth. It's not releasing the information it needs. So basically, it just kind of goes blah.
Exactly.
And all the whole body's vasodilates.
Exactly.
Right?
So we do need to do those spinal precautions here. We know that there's an issue, but with a more advanced practitioner, now we have to start kind of coming in and helping the body out.
Well, before, like we talked about, right, using vasopressors.
Exactly.
But if you're an EMR, the key part of this whole thing is the recognition.
Yes.
Because you understand how bad this is, you realize this is a really bad position for this patient. You can't spend an hour on scene with this guy.
No,
you need to notify the hospital, right? You're coming in and I got this thing and this is my level of care. So they understand that basically you're just treating with diesel.
Yeah, exactly.
Right?
This is diesel therapy. You're driving fast. Now, depending on where you are, this might be you're asking for an intercept. So you're driving over to the hospital, or you want an advanced care provider to kind of meet you to help out. Or if you're lucky to be in like here in Edmonton, we have stars. We can get the whirlybird to come and help out as well. But yeah, you don't want to be spending time just playing around. You want advanced.
What's that? It's all about recognition.
Yeah, 100%.
Right? Because if you don't recognize it, even if I'm a advanced care paramedic, I don't think there's anything wrong with them. Well, I obviously know there's something wrong with them, but I don't recognize what is wrong with them. I can't treat them properly.
Exactly. Like if I'm just there's some weird low BP here and I start pushing fluids, then I'm not doing anything. I'm not actually understanding the fact that there is shock here. So neurogenic shock, I freaking love this because it's just so crazy and wacky. It makes sense why it happens, but it's, I don't want it.
Well, and when you go through school, this is the oddball.
Yep.
This is when you go through school, you do your exams. You'll always see this on the exam because they're trying to see if you paid attention in class. Because this one's going to be so different than the rest of them.
Yeah, exactly.
Even within distributive shock realm, it's different than the other ones. It's different than anaphylaxis. It's different than sepsis.
Yeah, exactly. Because you're looking for that decreased pressure and that normal heart rate.
Yeah,
that's what makes you think, okay, neurogenic here. So the signal is being sent. However, it's not being sent to where it needs to go in order to get some type of proper effect. And like Jay said, if we don't treat this patient is going to be in for a really tough time.
Yeah.
Okay.
What we got next? Is this the
Well, right. Endocrine.
Well, this is a new one for me.
I
Well,
know.
not really a new one, but I probably have an idea.
So in EMS, we typically don't talk about this. Okay. So, due to underlying different endocrine etiologies or etiologies, whatever way you want to say that, so we can have adrenal failure, so Addison's crisis.
Yep.
Myasthenia, so hypothyroidism. There's also a couple other things that can lead to this. But if my endocrine system simply isn't working, if my hormone system isn't working, then I cannot create that adaptive change that my body needs to kind of help me out with shock. So, for instance, if my adrenal glands are failing, so in any type of shock, if my adrenals are failing, what can my body not send out?
Well, it's not sending out your those key hormones like norepinephrine, epinephrine, that kind of thing. And I've actually had an Addison's crisis patient,
which is crazy, right? Like, I mean, it's uncommon, but like we once.
So 25 years. Well, actually 30 years now, but all that time, what are the odds of seeing somebody like that?
Very slow. Very slow.
So like,
but the cool thing is when we look at these endocrine shocks, is we can have someone who is in a different type of distributive shock, let's say sepsis, where I know I have vasodilation and I should have a jacked up heart rate, but if someone has an underlying endocrine issue and they can't release that epi, well, this now looks like neurogenic, but it's not neurogenic. It's sepsis, but it's actually endocrine. Yeah. So in EMS, we typically don't tend to worry about this because we don't want to be like.
And a lot of times you don't. The patient that has this, even though you do good history, a lot of times you're not going to get this information.
No. Right? Especially if someone has like. There's many poor historians out there, and you guys are going to come across them, and they're going to say weird, wanky, wonky things that are all janky and they just don't make sense. That's the fun part of the job. But if someone also says that they have Graves' disease or something like that, are you going to be like, ooh, these are bad? That's where dead people go. No, if you don't know what it is, don't worry too much about it. You're going to be looking at the signs and the symptoms of what you can actually physically treat. Just once again, as Jay said earlier, diesel therapy, get to a hospital.
Especially when you first start, right? It's being able to recognize. So we're at the end of this one, but
spelling mistakes and all.
Oh no! So let's go through. I got one more thing. Maybe we can take a look at just to see to connect some of that stuff you just talked about.
Let's do it
and see how well it works. So we're gonna go over here. So one of these things we got going, as you were talking about, perfusion, right?
Perfusion is fun,
right? So we got 4 blocks. Think of it this way.
Okay, so I see some lungs.
So the first one, that's the brain, right? We're talking like, remember the neurogenic shock,
control center.
Control center. Then we have our lungs. It gets the air in and out, right? Get the oxygen, CO2 out. Heart, right? The heart's the pump, the one that pumps stuff around.
Super important,
right? And then you got your racetrack, basically is your container that not only has that but also has all your fluid. So when we're talking about
which we talk about today quite a bit,
this type of shock we're talking about, normal shock, our container is going to have lots of fluid.
Yeah.
Right.
So distribution is good.
It's all good. We can get fluid back and forth. We got enough in there. But when we have this distribution shock, the problem is that whether it's sepsis, whether it's anaphylaxis or neurogenic, what's happened is we've now lost control of that container and it's just gone blah.
So the fluid's the same amounts, but the container's bigger.
Right.
So it looks like I've lost volume where I haven't.
But what happens is when we talk about sepsis, when we talk about anaphylaxis and neuro, different things have happened.
Okay.
Right? They do the same thing, and that's why they kind of fall underneath the same thing. So when we think about, let's use neurogenic first, right? So the neurogenic comes down, sends out the signals, but now there's a block here, right? There's something broken.
Yeah.
So the signaling isn't going back and forth. So therefore it can't signal to do this. The body just goes, ugh.
Okay, so we stay in this distributive shock pattern.
You're still in this distributive shock. That's why what would happen is, if you think about it, we come in as EMS, we put a lasso around this thing, right? We give it some, maybe an epi drip or whatever. It could be some type of vasopressor. And basically what we end up doing is, what we're going to do is we're going to make that container, we're physically going to do the container.
Okay.
So if you think about it, this container, there's an injury to the neurogenic, right? It's out of place. it comes down, affects our container. Again, affects the heart, right? Because it's not going fast enough because it's neurogenic,
Yep, makes sense.
right? Same with our breathing. We're not breathing fast enough to get more oxygen in. So basically, it makes this whole stack unstable, right? So we can't. There's no perfusion going to happen here, or good perfusion.
No, yeah.
So I come in, I squeeze the tank with some epi. I'm gonna put that back into place. By doing that, I'm actually going to help put, our command center, our neuro back into place, because now we're getting blood to the brain, that kind of thing. That doesn't get rid of the injury or the reason why that's not happening. But what we're doing is like I said before, as EMS providers, we're going to try to keep those blocks in line.
Yes.
Either, and if we're lucky enough, especially if you're an ACP, advanced care paramedic, you can actually maybe push them back into line until you get to the hospital.
Exactly.
So you think of it,
and
right?
Then when you drop your patient off, it's no longer your issue.
Yeah, and that's not your problem. You run away the other way, right? But then again, we talk about anaphylaxis. It does the same thing, but anaphylaxis might start with a breathing problem.
Right. We get that
Right.
constriction of the
Yeah,
airway.
constricting the airway. We not get enough oxygen in. When we don't have enough oxygen, it starts to affect the heart. The heart's going to start beating faster. And the big one was that it creates this problem. And you can see easily how this block system that being stacked on top of one another, we're not perfusing.
Exactly.
So our job is, so if you're thinking, you're just an EMR, right? What can I do? But I show up and you're allergic to peanuts and butter, and I made you this beautiful peanut butter sandwich, and you're obligated to just ate it because you didn't want me to feel bad.
I didn't want you to feel bad. Yeah.
Right? And you have an EpiPen, and I show up, I can encourage you to have the EpiPen.
Yep.
In some places, depending on where you work, some places they call it Medisys. I can actually assist you. If you're not strong enough to actually hold that, I can help you hold it in place while we give it to you. As long as it's your EpiPen, has your name on, that kind of thing.
Yeah.
But again, I can get that epi going right away. And by doing that epi, we get constriction, right, in the vessels, dilation for the bronchioles,
Nice.
and then you can see how this basically comes back together. But the idea is that distributive shock, again, is the container isn't working well, and that container causes all these other problems. The last one, right, was sepsis.
Yep.
So again, sepsis is the same thing. We get that in there. You'll see increased heart rate, probably, unlike neurogenic.
Yep.
You're going to see some increased respiratory rate.
Yep.
But it's all because this block is out of place. And when that block's out of place, we create this instability in perfusion. And this is also, like, I don't know if we talked about it earlier, but it's hypoperfusion.
Yes.
You'll hear that word. What is shock? You can say hypoperfusion. People know what it is. Or somebody says, well, they're not perfusing well, or the hypoperfusion means they're still in shock.
Exactly.
So that just kind of gives you an overview of the idea how those work, like shock and distributive shock, especially because it's just that container is just not working out.
Yeah. Exactly. And what I like, and once again, I don't want to have this ever happen to me, but what I like about distributive shock is it's cyclical, right? So It doesn't matter what you've looked at. It doesn't matter if it's neurogenic or if it's septic or if it's anaphylactic. It doesn't really matter. But what happens is if you don't treat it, it'll make something else worse, which makes something else worse, which makes something else worse, which makes the patient die.
And that's like the blocks, right?
Yeah.
If they're all in line, you
You're
got that
set.
one. If you just have that one block that's kind of out of place, it's easy to come in and put a door wedge underneath it, right, and hold it in place. You might just give oxygen. But if you don't do that, if you're not getting enough oxygen into your system, it's going to cause problem to your heart. It's going to cause problems here.
Yeah.
It's like it just gets bigger and bigger, and the problem gets bigger, and then you end up with decompensated shock, or you get to the point of reversible shock. That's a hell of a lot of work, right, to get that back. So.
Exactly. Yeah. Once you start decompensating, then it's just not. It's just a battle in that ambulance.
So at the beginning, I didn't introduce myself. I just said it was Jason or Jay.
I just called myself Jay as well.
Yeah, I'm a paramedic clinical educator. I've been a paramedic probably for 34 years. So we're just trying to give back, trying to get people to understand some of the stuff a little easier. And you are?
So yeah, Jay Davis. So I was an advanced care paramedic for quite some time. I have a PhD in physiology, in cellular and molecular physiology, which is why I like talking about this stuff. Yep. And yeah, I mean, I remember going through this being like, this doesn't make any sense. And so we're just trying
to make it simpler.
Exactly.
And try to make it deeper so you can understand it.
Exactly. Yeah.
Right.
The more you understand about these things and the more depth of this you actually truly get, the easier your job is going to be on the road.
All right. So we got another one coming up. So we'll see you in the next one.
Take care, guys.